from IUA and Indian Stem Cell Study Group. We are in this very hot North India climatic zone, starting a very important program from Orthobiologics Subcommittee Group of Indian Orthopedic Association, evidence-based clinical use of orthobiologics. Let me share. Well, evidence-based clinical use of orthobiologics is very important, and we as orthopedic surgeons know that taking out a bone marrow is not a big task, but we have to work up for all those legal issues for catching up the right choices for the right cases. And that is very important. That is why evidence-based medicine, which is a very important target point for our clinical practice, is the main target for this evening. Definitely, we all know there are a lot of indication in orthopedics where we can use regenerative science, maybe as a PRP or a Bmac, right from the fracture non-unions to the ischemic limb, to the avascular necrosis, to the osteoarthritis, and to so many autoimmune diseases. Like in India, we are still having 3% of autoimmune diseases as a rheumatoid arthritis, in which sometime it has been required. So what we can do is we can always have such initiatives, such support for the basic and transitional research work for the use of stem cells in various challenging orthopedic conditions, but in the regulatory framework, so that we can have a good original publications from the very reputed index journal from India. As we all know, we have a lot of potential of the clinical practice. ISCSG Association is always promoting its member for the meta-analysis and all the research work. And we have our own journal attached with the International Journal of Orthopedic Rheumatology. We are promoting all the research work. So over to this webinar, I welcome all the speakers, our respected IUA President, Secretary. Professor Chinmoy Das is not able to reach. He's the convener, but he'll be joining soon. And the other dignitaries, the stalwarts who are here to give their comments for this meeting. Yeah, thank you. So I'll now request our President, Professor Ramesh Sen, sir, to just have introductory remarks. So.
Thank you, Dr. Manish. Dear friends, very good evening. Now we all know it's a very well perceived fact that the biological repair mechanisms definitely score much better than the mechanical reconstruction or replacement now for many orthopedic diseases. Definitely, this is a very noble way to actually reclaim our natural abilities rather than really depending on the technical things. I'm quite happy that our senior people like Dr. Manish, Dr. Sandeep, I mean, these people have been working for, and I'm very happy that Indian Orthopedic Association, the Orthobiologics Committee, is working with a very clear focus to make all aware of the potential this orthobiologics might hold for many of the diseases. I am really thankful again to Dr. Manish for this very active effort in the specialty and to have organized many such webinars. And even in today's webinars also, as you see, the programs is likely to be very interesting because we deal a lot with those basic facts which we need to know about the day-to-day problem which we are likely to encounter. I'm sure all the participants who listen to it, who watch all these presentations are likely to get a reasonable amount of a stimulus to look further into this science and definitely to make it use in the care of their patients. Thank you and all best wishes. Thank you, Dr.
Thank you so much, sir. Thank you so much. Thanks a lot. We will be not waiting for Professor Das. He's busy. So I'll take this opportunity to start, and with the permission of our President, for the session A, which is mainly into the basic of orthobiologics and such conditions which are clinically commonly in use, like critical ischemia, and what and how to go for the PRP. And definitely PRP and PRF are very confusing thing, which will within a one hour time we'll be able to find it out which is better and why with the evidence base. So I'll just take the permission to share my screen for my presentation. Well, the significance of orthobiologic in clinical practice, it is definitely there. We all know that significance is very much there because in the clinical practice, there are a lot of challenges, like maybe it's an avian or it may be some a condition like ischemia, where we require actually a particular modality to give results to the patient. Indian Stem Cell Study Group Association and IUA, we are working together just to bring out the most latest things into the clinic, which is important for the clinical practice. Rather, what and how the stem cell is a pronoun, actually misnomer. It should be a progenitor cells, which are important in the orthopedic practice for all practical purposes. For decades altogether, orthopedic means fractures, and fractures. I think when 20 years back, I was a student, as an MSc student, I was also mainly concerned for the fracture. So fracture is definitely bread and butter, but even in the fractures, there are some challenges. Then we have a 2 revision, 3 revision for the non-union, and the results are not there. So we have got some choices for that. Like definitely the biomechanical stress which we give the patient for walking, maybe in a delayed union, when a railroad has been given or Elizaro has been given or whatever external fixator has been given, how it works at the microscopic level, the answers would be there in next 10 minutes of the time, how it works. So it is the same science which we are using, but just unfolding those things which we are not able to catch up that time. So the cellular therapy, the better name is the cellular therapy, has got a positive biomechanical role. So with the fixator system on walking, it has a biomechanical role, or the cellular therapy has also got a biomechanical role. We are all aware of the cascades of the biological repair, but just to revise, definitely whenever any injury to the soft tissue or any fracture is there, the first thing is the platelets, which they release a lot of growth factor, and the most important is PDGF, because that is a thing which stimulates the stem cells running to the injured site for the angiogenesis. Because as orthopedic surgeon, we are always afraid for the angiogenesis. Maybe it's, we always feel like whenever we operate a patient with a fibrosis for the revision of the surgery, we always find that angiogenesis is a bigger issue. Secondly, GCSF is again released from any damaged tissue because of the macrophage, and that again mobilize lot of stem cells, blast cells from the bone marrow. So here you can see when the wound is there, platelets are there. They release PDGF, VGF. There's a lot of many platelets growth factor, which I'm not going to go in detail. We have a separate lecture for this. But definitely these PDGF, PDAF, endothelial growth factor, they are very important, and they are the base of our results to the patients. By the patients are happy, we are happy. It is all because of this microscopic growth factor. And now with the year, we are very much clear that why there is a wonderful healing with any damn fracture in the children, if it's not osteogenesis imperfecta, because the children, they have got 10 times more stem cells per milliliter of the bone marrow, which is a big boon for us in the clinical practice for going for conservative management. So it is again because scientifically they have more stem cells, and that we are having the gain for it. The definition of the delayed union or the non-union is based actually, rather I will say was based actually on the nature of the fracture with the potential to heal. But now the definition has been changed. But before that, I will just like to say, whenever we make a patient of a delayed union, in which we find that it will be going to unite soon by walking, by weight bearing, maybe on Elizaro, maybe on X-Fix, anything. It is simply the stress which is being given at the fracture site to the progenitor cells. And it has been proved by flow cytometry that whenever there is a stress which is being given to these progenitor cells at that so-called as fracture site, delayed union site, then it stimulates them and it goes into multiplication. And that is the reason when our professors used to give a PTB cast and ask the patient to walk and unite, fracture unites. So the definition of, cellular definition rather, of the non-union would be, non-union is defined as a site where the MSCs or the progenitor cells at that particular pace has a poor status of proliferation and differentiation. By making a use of cellular therapy, we can stimulate that proliferation and differentiation and form other results. So it is just as plain as simple. Percutaneous placement of any PRP, any Bmac or autologous MSC, whatever surgeon wants to go for it, it simply stimulate the resident cell there to multiply, to do the things, because the growth factor also present in the PRP, they do a wonderful job. And the local inhibiting factor, all those local factors of the malunion or delayed union, which are there in our books, they will work less if this PRP, Bmac, autologous MSCs, MNCs, or walking is being done. So cellular therapy for now, as of now, it is Bmac or PRP have the potential to unite a fracture in a delayed or non-union, even if some fibrous tissue is there, and the proof is there. If you see in the practice 15 years back, if the patient with a conservative management of TBS coming and there is a delayed union, we give a PTB cast and to make them walk, because little bit of fibrous union may be converted with a good walking. So there are many other factors. We are not going to go into details, but definitely it works. Now, the other conditions like metabolic bone diseases, metabolic bone diseases such as osteogenesis imperfecta, hypophosphatemia, there are other conditions where the repeated fractures are there. So that is a different story, but definitely again, the regenerative science has got an answer to this. Osteogenesis imperfecta is a condition we all know that where the fragility fracture is there. If you go back to the literature, in previous century, in 1999, Horwitz et al. Have reported 3 osteogenesis imperfecta children who have been transplanted with allogenic MSCs from HLA compatible siblings, and there were lamellar bone formation, improved osteogenesis with fewer fracture. The question is not that we are able to treat it. The question is that it works actually. In grafters, MSCs were shown to differentiate into osteoblast. We did in 2011 and 2014 2 cases, free cases, in which some have donated their MSCs with the help of some companies. We were able to do, and the second dose was a allogenic MSCs in which the transplantation was being done, and the results were wonderful. And here is a small interview in which we can have a note from the patient how the recovery was. I'm sorry, it's not working, so we'll do it sometime else. Well, Bmac cell types. So Bmac, when we say Bmac, we are just focusing on the cell types. So the cell types in Bmac is hematopoietic stem cells and mesenchymal stem cell. But mainly the population is hematopoietic stem cells, CD34 cells, CD45 cells. And the aim is again to secrete the growth factor, to take the advantage of the growth factor secreted from the hematopoietic stem cells. Now, mesenchymal stem cells are also there, but they are very few in number. So whatever the effect of Bmac is coming, it is mainly the hematopoietic stem cells, CD34 cells, some mononuclear cells, and a lot of the growth factor. Because ultimately, it is the growth factor which are going to help. Now, a very routine question, where stem cell lies. So stem cell is present at all the places in all the bones, but special the niche is an area where a specific microenvironment is being given to the progenitor cells, to the mononuclear cells, to reside, to live, and whenever it's required, to release in the bloodstream to reach to the target. And for all orthopedic surgeons, the practical part is our iliac crest, because that is a zone where the lot of environment is being given. Now, MSCs differentiate into osteoblasts, chondroblasts, fibroblasts. So we all know this thing. I'm not going to again into detail, but definitely PRP or Bmac is used, was used in maybe in a legal aspect or whichever aspect in the various sports injury cases, and the proof is the relief which is being received by a number of stalwarts of the sports industries to the date, and it it is definitely a boon. In 2002, I've come across a paper in which the cartilage regeneration was being mentioned in osteoarthritis, where a distraction was being given, a negative pressure was being created in the knee joint actually to prove that cartilage regeneration is there. Why I've placed this slide is just to explain. For me, actually, like I'm doing a lot of club foot for the last 2 decades. And for me, always, whenever there is a distraction with the histiogenesis, with the soft tissue correction, with the adduction, abduction, equinus deformity correction, I used to have all these cases with a good dome of the teller regeneration if it is not being spoiled, actually. So this principle I was able to explain here only, that when the distraction is there, endogenous pool of MSCs, progenitor cell distraction at any place actually, present in that area, maybe the synovium, maybe in the periosteum, maybe in the subarticular space, they get stimulated, they release the growth factor, they multiply, and they do the remodeling and give a good result. And so in all these cases, when the club foot till today, when we do it, maybe it via Lizarro, maybe by GS, or whatever modality you want, there is a good regeneration of the articular cartilage. The regeneration of articular cartilage is possible. The question is, the challenge is where to pick it up. Not in all the cases of osteoarthritis, not in all the cases of any damage of the ankle or hip. It has got a little some potential. We are not supposed to take a hibernated state. The right patient at right choice is very important. Recent researchers by Wigan et al. In 2030 have proved that the cartilage regeneration when distraction of the joint is being done, and they have proved in the osteoarthritis ankle. But the question is, should we in all the cases of a knee or an ankle should do a distraction osteosynthesis for regeneration of articular cartilage? No, because there is again a handicap, you can say, that whenever the distraction is being done, we need to have a cyclic compression on the cartilage also. Why? So as to eliminate any beneficial anti-inflammatory and anabolic effect of mechanotransduction on chondrocyte. So that is why it is not a treatment modality to distract a knee joint or distract the ankle joint to go for a cartilage regeneration. For sure, for any case selection, anything, as I've already said, the proper case selection is very important. So MRI is the best answer, especially the DAS sequences, T2 mapping, where we can see how much it is being damaged. If you're not going for arthroscopic, then definitely we have to go for this thing. And there are publications, there are proof in the literature. In 2008, it was well proved that you can see here, pre-injection MSC was being given, where the cartilage mapping was being done, and it is such a hibernated state. And gradually, after 6 months, it has been thickened up. Now, evidence is there, only the clinical trials have to be done, which is having a lot of hiccups, a lot of things to work up actually. So evidence-based medicine, evidence-based orthopedics, evidence-based regenerative science is very important to make it proof. And if we are able to do in evidence-based manner, then the things are very good. There is definitive role of cellular therapy or PRP in orthopedics in all the interventions. So I can't go in the detail, but definitely fracture healing, non-union, delayed union, cartilage repair, OA, tendon skeletal muscle repair, spinal cord regeneration to some extent, a very gray area actually. Sports injuries, partial ACLTL. Yes, it works in partial ACLTL, provided it's partial actually. Meniscal injury, but not all the type of meniscal injury. How can we expect a bucket handle tear to heal actually? In avian or for any other osteochondral lesion. So, and definitely in critical limb ischemia, maybe traumatic or secondary diabetes. We have got a second lecture on this also. In Berger's disease, yes, we have got some cases in which the results are there, but again, a clinical trial is to be required. I'll just place a simple example because we can't go in detail. For a tissue engineering triad, which is very important for orthopedic surgeon, which we do regularly, means if you have a signals, if you have cells with them, and if you have a bioceramic allograft, maybe G-bone or whatever it may be, with a signaling molecule, then we can give a good effort. And the best thing is avascular necrosis head of the femur. Whether core decompression, of course, core decompression can produce a good result. Sometimes say it's difficult actually whether this core decompression is given a good result or whether the Bmac after the core decompression is given a good result. But definitely the papers are there, the publications are there, which have shown a better response with the core decompression with a Bmac. Idea is to preserve and replace the head. After the COVID, we are seeing a surge in lot of avian cases in the hip. Young patients, we don't know how it's happening, but definitely there's a surge. And but again, a proper case selection. I've just taken one case only here, a 30-year male with an MRI showing a crescent sign, partial subchondral collapse. So ideally, a partial subchondral collapse should also not be there for a proper good result. But definitely, if a crescent sign and an early condition, grade 1 condition, grade 2 condition is there, the results can be done. Core decompression with Bmac, with doing a drilling and whatever the protocol is being followed. And then gradually, this is a slide in which I've explained that after 1.5 years, we can see a good joint is maintained. See, people ask me, what are the, what are the results? There is no much wonderful changes seen in X-rays, but the most important thing is the collapse still, if it's not been done for 3-4 years, the pain has been gone, the articular space has been maintained, then yes, it works very well. But the most important thing is the age of the patient, stage of the disease, location, what are the other comorbidity factors, because many times hyperuricemia is a common condition associated with all these patients. Underlying cause of avian is very important. What is the time when the cause part is being eliminated and then it to be attempted? So there are so many things which has to be decided. So summary, we carry our own action kit in the body. Several studies and trials have been there, not much from India, but definitely they are there. You can go into Google and see where the results have been there. Here are a few references. We have got the textbook of orthopedic rheumatology, where is a dedicated section on regenerative part of orthobiologics has been there. That can be worked up, that can be seen and learned from the book. Definitely, ethical implication of regenerative medicine in orthopedic is very important, not only in regenerative medicine, for all the things in a day of today with a lot of medical legal issues is very important. And the question of ethics, whether the autologous cells are there to sell the treatment by the profession. So there are still a lot of publications. So I think the most important thing is to know, to learn, and where to be used with all the precaution, with all the things in the proper shape with the regulatory bodies. That's very important. Thank you so much for a very, very patient hearing. So I'll stop my presentation here. Can I take the permission to request Dr. Mahapatra, sir? Professor Mahapatra is from Burla, Orissa. He's a very senior surgeon who has done a lot of work on and a lot of wonderful publication on critical limb ischemia. Mahapatra, sir, are you ready? Professor Mahapatra, can we start your presentation now?
You please present. I will ask you slide.
Yeah, sure. So there is some technical issue. So I am sharing a slide from my side, and he'll be presenting, and I'll be. So it's here. You can say next, then I'll move the slide of your slides.
Yes, please. So I'll be presenting my experience. Good evening, everybody.
Your voice is not clear. Can you position your mic?
Okay, good evening to everybody. Thank you, Professor Manish, for giving me this opportunity online to present my experience of cell therapy in peripheral vascular disease and different other ulcerations of the lower limb. And this has been already published in your textbook. Am I audible?
Sir.
Am I audible?
Sir, please, yeah.
Please, next slide.
Sir.
Change the slide. Now, here is a patient who presented to me with with this type of ulceration. You see, there is ulcer on the dorsum, and there is gangrene of the great toe, and there is all gangrene of the other toe. So this is the left foot, and this is the right foot. Now, the duration, he had intermittent claudication history for 1 year and rest pain for 2 months, and this discoloration of the foot and great toe for 2 months, and the ulcer over the left foot for 20 days. Next slide, please. Please. Now he is a known case of hypertension and diabetes also, but there was a history of coronary artery disease, and he had PTCA done, and he was on clopidogrel and atorvastatin, and there is no history of any alcohol consumption or tobacco, but he had a history of smoking for around more than 20 years. He has a normal mixed Indian diet. Next slide. So patient was admitted to a private hospital in Raipur initially in November 20, where Doppler scan was done, and it showed bilateral popliteal artery and blockage of the dorsalis pedis artery occlusion. CT angiogram was done, which showed thrombosis of the bilateral popliteal arteries and tibial-peroneal trunk, and there was opacification of the anterior tibial artery, distal 1/3 of the anterior tibial, and patchy interrupted opacification of the bilateral dorsalis pedis. Anyway, he had a severe distal block. Next slide, please. He underwent a bilateral popliteal artery exploration at that hospital in December, and there was no symptomatic improvement. Then since last 1 month before coming to me from the hospital, patient visited several other hospitals where patient was treated conservatively without any symptomatic or objective improvement. Next please. Next please. Next slide. When I examined him, I found that the complete blast discoloration. I showed you the picture in the first slide, and the left foot was congested, edematous. There is evidence of chronic ischemia, like a loss of hair, loss of subcutaneous fat, diminished growth of thin skin, and black discoloration over the tip of the right great toe, and ulceration and gangrene of the great toe on the left side. Next slide, please. So the scar of bilateral popliteal artery exploration was also visible, and the ulcer that you saw. And next slide, please. Next slide. I will not repeat it. Next. And this was the status of the dorsalis pedis. Left side was absent, posterior tibial absent, while in the right side there was a plus, only one plus, and the femoral plus. Both sides were almost equal, but in the left side the popliteal was weak, and anterior tibial are absent, posterior tibial absent, dorsalis pedis absent in the left side. Next please. That means he had distal obstruction completely in the left side, but little obstruction in the right side. Next one, please. So we made a diagnosis of peripheral vascular disease with critical ischemic limb, with diabetes and with hypertension. Next, please. And we did all the investigation, and we sent the cholesterol and triglyceride, etc., and blood sugar estimation, and pause for culture. And we also again made Doppler study. The popliteal artery block was confirmed with diffuse arterial disease and the popliteal downwards. But the normal venous Doppler study was found. And we made a cardiological and general medical consultation. Next slide, please. Then we harvested the bone marrow. We saw the last research. It has already been attempted for arterial reconstruction, which has failed. And we have started for a cell therapy, and with informed consent, as the protocol and institutional ethics committee clearance, we harvested the cells. Next slide, please. And this much of bone marrow we harvested, and then with heparinized, so because it will otherwise clot. And then next, please. Next slide. Next slide. and we transferred this to insulin syringe. From 10 cc syringe, we took into insulin syringe, because if we hit with thicker syringe, thicker needles, then the trauma will be more. So with insulin syringe, we gave the cell therapy. We injected the cell, we transferred the cells. Next one, I'll show you. Please, next slide. Next slide, please. We now transferring the cells directly into the popliteal area of the affected side and to the other side also. Soft tissue injection. We are not directly injecting to the artery or vein, or we are not giving infusion. We are giving to the subcutaneous tissue, because there where the collaterals will be present, and even if not present, collaterals will develop the angiogenesis, and the arteries to the end arteries to the peripheral nerves, the cutaneous nerves will develop, and then rest pain will improve. With that intention, we injected into the soft tissue of the popliteal area. Next slide. And to the ulcer bed. Next, please. This is soft tissue injection. And then we injected into the ulcer margin. You see, we are injecting the ulcer margin. That ulcer margin. Next, please. Next slide. And then we did the dressing. Next slide. And patient rest pain decreased. On the rest pain decreased 30%, and patient able to sleep. And the after a long of suffering, he could sleep that night. So it acted within 3 to 4 hours. It acted because of cytokine effects, not because of immediate regeneration. The cytokines prevented the receptor, pain receptor transmission. And then post-operative 5, patient was discharged and able to walk with few steps, and leg pain decreased. Post-operative 19, patient came for a checkup. Leg pain decreased by 40%. Floor of the leg also showed increased granulation tissue as compared to previous. Next slide, please. Now you can see we have not amputated the gangrenous toe. The cell therapy, the quality of granulation tissue has improved. His rest pain has improved, and he is able to work with the cell therapy. Next one, please. Then with this admission, we amputated the gangrenous toe, because technology is not available with me now. How to replace that toe? If I have scaffold technology, which is practiced in National Institute of Technology, with their help, we could have implanted toe scaffold with cells to develop these toes. So that technology, that technique, or that skill is not available with me. And if Professor Manish, who is our head and our chief of our cell therapy, can plan a scaffold technique to lost organs like these toes, to nose, to ears, or even to anywhere else, skin, scaffold can work wonders by creating the organs in future. This is another possibility of our cell therapy in future. So, but since this scaffolding technique is not available with me, I just amputated the toe. You can see, and you see the quality of the granulation tissue. You saw that time, and this time I amputated. That time I did not amputate because the infection may spread or something may. Next one, please. Next slide. Now you see, this is on post-operative day 32. This is the photograph of the patient. You see the quality of the almost healed, and the ulcer in the dorsum has healed. So the mechanism, he has come from different. So there is no question of bypassing. There is no question of stenting here. What can I do? It is not possible to stent when there is not possible dorsalis pedis, posterior tibial. You cannot stent the digital arteries. You cannot do plantar arteries. You cannot stent. Only by vasodilator it is not going to help. Vasodilators is not going to help. That we have like this, or you have this. So it's a wonderful result I obtained in this patient. And in many other patients also, then I applied and rest pain dramatically improved. You can see any patient presenting with critical limb ischemia, if you give simply bone marrow aspirate, simple, don't separate the cells, bone marrow directly into the soft tissue, there will be a dramatic improvement of rest pain. And this you can give me a collaborative study and see how it is working. Next slide, please. So I will conclude that peripheral arterial disease is most commonly caused by atherosclerosis or thromboangiitis, Borges disease, can lead to claudication, critical limb ischemia, often resulting for major amputation and subsequent death. Next, please. Next, please. So this is the mechanism. Everybody know. Next one, please. So the factors already Professor Manish has elaborated: angiogenic, vasculogenic, and arteriogenic processes. And next slide, please. I will not repeat. This is how the process of angiogenesis takes place when you are injecting to the soft tissues. Next, please. So chronic atherosclerotic and diabetic patients with critical limb ischemia may impact the vascular regeneration, where oxidative stress, chronic inflammation, and lipotoxicity, glucotoxicity causes progenitor cell dysfunction, including aberrant proliferation, differentiation, migration, mobilization, and signaling. This can be prevented when you are giving directly cells to the local tissues. Next one, please. Now, this is the study, Christian et al. Established that CD146, we have already, Professor Manish has elaborated, express pericyte fulfill the criteria defining mesenchymal stem cells, and mesenchymal stem cells differentiate into bone, cartilage, adipose tissue, and angiogenic immunomodulatory factors already have been nicely elaborated by Professor Manish. Thus, mesenchymal cells represent a third progenitor cell lineage that stabilize the vessels and provide secreted clues to the supporting vessels for maturation. Next, please. Autologous cell therapy for peripheral vascular disease and a review of meta-analysis. This is available in this journal. So these are the journal primary, and so many studies already proved that mesenchymal stem cells working in peripheral vascular disease. Next one, please. So these are all publications. Next. I will conclude that standard treatment for such severe cases, which I elaborated here, for peripheral vascular disease, by endovascular revascularization or stenting is not sometimes possible, the standard treatment. However, up to 30% of patients are not candidates for such interventions due to high operative risk or unfavorable vascular involvement, which this patient had. You have already seen the CT angio. Next, please. Therefore, new strategies are needed to offer these patients viable therapeutic options. And stem cells derived from the bone marrow have been identified as a potential therapeutic option to induce angiogenesis and saving the patient's life, and he is modulating the life and saving a life and the limb also. Thank you, sir. Thank you.
Thank you so much, sir. Thank you so much for a wonderful presentation. We are extremely thankful to you for such a nice presentation on the condition critical limb ischemia. In a country like India, where 2 to 3% are diabetes, and it's still it's a boon actually to have. It is always said, there is a proverb, necessity is the mother of invention. So with so much of disease burden, increasing burden, and if we can work it up definitely with a CT scan and exactly find out what is the lesion site. Definitely these terminal ulcers which are not going to heal, the patient are coming in the terminal stage of the amputation, can be minimized. Thank you so much, sir. Thanks a lot.
Thank you. Thank you.
So we'll take up all the questions. There are some few questions in the chat box also in the end. So now I'll request Dr. Ravi. We are Ravi from Trichy for the biological properties of PRP. I think Dr. Madan will be able to flow the slides.
Yes. Good evening, Professor Manish. It was an excellent lecture from you and
Thank you so much.
So actually, in continuation of what the previous speaker has been talking about critical limb ischemia, one point I would like to add is India is the first and only country in the world which has got mesenchymal stem cell therapy allogenic approved by FDA.
Correct.
Suppose a patient is there in USA, he is there in Europe, who has got a similar problem of a non-healing ulcer with a vascular occlusion. If he wants to get an FDA-approved therapy, he has to come to India.
Yeah,
yes. So that is point number one. Yes. And next point is regarding your talk, Professor Manish's talk. So I loved the definition, the latest definition, which includes the molecular basis of a delayed union or non-union, where it is the dysfunction of the progenitor cells. And one small addition, what I would like to say is you are saying that there were not many Indian studies, but actually, if you want to look into the work, the clinical work and the publications of the two premier institutions of India, namely Chandigarh and AIIMS Delhi, particularly Professor Sen's work on avascular necrosis, Dr. Anil Bansali, his work on stem cells for diabetes. And similarly, actually, there is one more study going on in Delhi, AIIMS Delhi, in the Department of Gastroenterology, where they are studying the healing of anal fistula due to Crohn's disease. So Crohn's disease, non-healing anal fistulas, there is a trial which is going on for allogenic mesenchymal stem cell injection for healing, which will now be available as a product. Soon, it will be available after some time. Similarly, one more product for osteoarthritis is in the waiting list. Already it is approved by the FDA. And again, as I said, like a patient with critical limb ischemia, if there is a patient with osteoarthritis in USA or Europe, and if they want an FDA-approved therapy, they have to come to India. So this is
the only thing is the cost actually, which is hampering all these things. So definitely
the cost will be taken care. No, the cost will be taken care by the partially by the insurance, because once it is approved by FDA, the product has to be sanctioned by all the insurance companies. So whether it is the government insurance scheme or the private insurance scheme, they will have to cover, and they cannot escape because it is an FDA approved therapy. So with this short introduction, I want to go into the basics of platelet rich plasma, which is the topic given to me. I work in Maruti Hospital, Trichy. Next slide. So if you want to understand the basics of PRP, then I think you should have a basic understanding of the process of healing. What are the stages of healing? What is delayed healing? Similarly, any other tissue in the body, if you should know about the hair growth cycle, because a lot of dermatologists are nowadays using PRP for hair regeneration. So how does PRP work? If you want to know, then you have to study about the hair growth cycle. What are the phases of hair regeneration? So similarly, there is PRP is used in infertility. So if you want to understand, then you have to know what are the basic molecular basics behind the endometrial cycle, the thickness, how the endometrium gets thickened, and what are the when is the vascularity maximum. So, and again, musculotendinous integrity. So orthopedic surgeons, we have been treating muscle injuries, ligament injuries, tendons, capsules, cartilage injuries with previously with steroids and other drugs. But now for the past 2 decades, we are having the option of treating these muscular tendinous injuries and cartilage injuries with PRP because it is the new mode of regenerating. Previously, we were not getting the possibility of regeneration with steroid injection or pain relief. And nowadays, there is more propensity to go for nerve blocks. So we cannot compare nerve blocks with these PRP treatments because it is like comparing apple to orange. Because these nerve blocks will never do regeneration. They are temporary relief of pain. Whereas these biological therapies with either PRP or stem cells or regenerative therapies. So the comparison ends at the stage of pain relief. But if you go deep, you can see that there is a possibility of regeneration. So to understand the basics of PRP, we should be well versed with the physiology of all parts of the body, as I said, from cartilage to ligament and the skin, endometrium, hair, etc. Next slide. So in this talk, we will be talking about the definition, the content of PRP, and then the types of PRP preparation, mechanism of action, the uniqueness, as well as additions to PRP. What can we do? What can we add to PRP to improve the results? And the known and unknown of PRP. Next slide. So the definition, it is commonly approved that the supraphysiological concentration of platelets in plasma is defined as platelet rich plasma. But how much times, how many times, whether it is twice or whether it is 3 times or 5 times or 10 times or more. So in general, most of the publications feel that it is 3 to 5-fold increase in the platelet count is what we can count as the platelet rich plasma. And there are studies again which show that when there is a difference in the amount of PRP, then the healing is also different. So the 2.5-fold increase in the ideal level for osteoblast and fibroblast growth has been proved by one publication. So we should be aware of, and we should be doing a lot of basic work. And in every situation, see for a ligament injury or for a meniscal injury or for a cartilage injury, how much is the number of times the PRP has to be more. So there is a lot of basic work which we have to do. So we have got young orthopedic surgeons whom we are training in these specialties. So they can take up topics like that, and then we will be able to give guidelines regarding each tissue, whether it is a fascia or ligament or cartilage. So the difference in treating those things. Next slide. So the method of preparation, there is usually done as in 2 steps. The one is the soft spin and the other is the hard spin. The first, it is done to first separate the RBCs. So when we do the first spin, we get all the RBCs down and then we remove the plasma, leaving behind the RBCs. And then the second time when we spin, we want to get the platelet rich plasma by eliminating the platelet poor plasma. So after getting this centrifugation process, the next important step is the activation of the platelets. So the platelets have to release the growth factors. So the growth factors like VEGF, the FGF, the epidermal growth factor, platelet-derived growth factors. So all of them have to be released by the platelets. So for that, we have to either use a calcium chloride or thrombin, or freeze thawing is a best way of releasing the growth factors. But when we inject the PRP into the tissue, when the platelets come into contact with collagen, particularly type 1 collagen, it is automatically an activator of the platelets and enabling the release of the growth factors. Next slide. And what does the activated platelet, once we activate, what does the platelet do and how do they release the growth factors. So you can see there are a lot of microtubules and microvesicles which are in the content of the platelets. So platelets are just simple cells. They don't have a nucleus. Their main purpose is to carry the growth factors which are essential for healing. They are actually the healers of the body. So whenever there is an injury to any tissue, the platelets are the main initiator of the healing process. And that is why they contain all the necessary ingredients which are needed, like the growth factors. They not only contain growth factors, they also contain antibacterial peptides and antiviral peptides also. So it is not only in helping in the repair and regeneration, they also help in preventing the infection by their natural process. Next slide. So what are the mainly the dense granules, the alpha granules, and the lysosomal granules? These are the granules which contain these growth factors, and most of the most important growth factors which we know, like the PDGF, VEGF, epidermal, and insulin-like growth factors, they are all there in the alpha granules, which when they are released, they help in the healing. As I told, apart from these growth factors, there are a lot of other essential ingredients. Even the energy required for doing the healing process, like ATP, ADP, the calcium which is involved, and the other elements. And apart from that, as I said, the antibacterial peptides. So the platelet itself is working like a pharmacy. It is working like a medical store, which helps in using the appropriate growth factors and elements which are needed for the regeneration of the tissue. Next slide. As I said, what are the types of PRP? Now, when we take it from the same patient, we know it is called as the autologous. So as I described, these two steps of the soft spin and the hard spin to separate the platelet-rich plasma, and then activation, and then it can be used. But at the same time, allogenic platelets have also been used in many situations. The blood bags, the platelet bags, which are available in the blood bank, the platelet bags should be used within 6 to 7 days, because the platelets cannot survive more than 6 to 7 days. So when they are being discarded on the 6th day, you can get the platelet bags and then concentrate and then use the allogenic PRP. And there are a lot of studies which have used allogenic PRP. And I think in India, Professor Shrivastava, Sandeep Shrivastava, has been pioneering this in many situations where he has consistently shown very good results with not only healing of the ulcers in diabetic ulcers, and also in other very difficult situations. And one more point to ponder is that what is the role of WBCs? So the WBCs, what do they do? And should we eliminate the WBCs totally? As I said, and there are other issues like whether we are going to use only PRP or whether we are going to use PRP with scaffold and PRP with scaffold and stem cells. As Dr. Manish described, it's the triad. For the regeneration, you need the cells, you need the growth factors, and you need the scaffold. When there is a gap in the bone, for example, when there is a gap non-union, only the growth factors alone cannot help. There we have to fill the gap with a scaffold, like the tricalcium phosphate or the hydroxyapatite. And then we have to inject either the PRP for growth factors or the stem cells. So PRP alone may not be working in every situation. So we should find out in which situations we have to use PRP with a scaffold, and where we have to use PRP scaffold as well as stem cells. Next slide. Again, as I said, the role of WBCs, why we want to eliminate as much of WBCs as possible, because some of these WBCs which have like neutrophils, they have got cytotoxic elements and cytokines which cause destruction and which can have a catabolic effect. So they can suppress the bone formation also, and therefore they may delay the bone healing also. So if there are more WBCs, then there is chances for more inflammation, and in certain situations, it will suppress the bone formation. Next slide. Yeah, next slide, please. Yeah. So, as I said, autologous and allogenic, what are the advantages and disadvantages? In allogenic, the greatest advantage is that it is readily available, and the quality, not only the quality, the quantity is more, because multiple doses can be given. When we can give multiple doses with allogenic without taking the blood from the patient every time, in situations like chronic ulcers or hair regeneration, where there is need for multiple doses, every time we need not take from the patient, we can use allogenic sources. Whereas autologous has got a very good safety profile, because not only it is immediately prepared and immediately used, there is no loss of the growth factors. So in certain situations, autologous are better, whereas allogenic may be useful in other situations where repeated injections are necessary. Next slide. And any side effects to PRP injections? Yes, they can cause irritation, they can cause pain, and we should be very careful when injecting in percutaneous route, because we should avoid irritating certain structures like the nerve, because it can cause some severe pain. And in some patients where there is known allergy, it is better to avoid the allogenic source and go for autologous. Next slide. Yeah, next slide, Madan.
Dr. Madan, next. Yeah.
So the frequently asked questions about the PRP. Do PRP help in regeneration? Yes, definitely. The PRP is the first step in regeneration. Orthopedic surgeons have been introduced. So we have been a very, very staunch user of steroids. From henceforth, we should avoid using steroids, and we should use PRP wherever we have used steroids, because they help in regeneration. So ideal quantity, is it known? No, we don't know. A lot of studies have to be done. Is there general safety? Yes, general safety has been proved. And is it there any specific contraindication specific to cancer patients? Yes, it is better to avoid, and it is better to screen the patients for cancers, existing cancers, because we don't know how much of that platelets can increase the angiogenesis and worsen the situation of the cancer. So like many drugs which we avoid in pregnancy, which we avoid in cancer, this PRP also has got contraindications in cancer patients. So mechanism of action, is it known? Yes. We have thoroughly studied about the how the platelet-rich plasma works, what are the growth factors, and what are the other peptides which are there in the platelets which help. So the mechanism of action has been thoroughly studied. But again, we have to do a lot of work to know the complete knowledge about the platelets and the growth factors. So do we know the mechanism of action fully? Yes, there are certain areas yet to explore. So with this, I think we are giving an opportunity for the young orthopedic surgeons to do research in all these points. So for all the answers of no, and we want to do some standardization, how much to give in each pathology. So the safety mechanism of action, we need more research and more publications. So that is again the role of the orthopedic surgeons and orthopedic fellows. Yeah, next slide. So the latest concept is the lyophilized platelet-rich plasma, where we can convert the allogenic or even autologous PRP into, after releasing the growth factors, the plasma can be made into a powder form, and that can have a more stability for a longer duration. It can be stored in 4 to 8 degrees up to 1 year. So the growth factors will be stable. If we use it in a liquid form, very frequently the growth factors get degraded within hours. But if we store it in the lyophilized form, it will be available for almost 1 year in a regular fridge. It can be stored in the pharmacies. Next slide. And this lyophilized has got the growth factors which have been measured. The one more advantage of the lyophilized growth factors, lyophilized PRP, is that the growth factors present in each milligram of the PRP powder is measured. We know how much of VEGF is there, how much of FGF is there. So it is like giving paracetamol. We want to give 650 ml, or we want to give a particular drug in a particular dose. So similarly, if we should know what is the dose which is being given to the patient. So the lyophilized form will help us in knowing exactly the amount of growth factors which we are delivering. So with these words, I thank the opportunity. I thank the organizers for giving me this opportunity.
Thank you so much, Dr. Ravi, for a wonderful, excellent presentation, especially the target given to a lot of young orthopedic surgeons to unfold so many things for your nose. And definitely in coming years of time, we'll be able to have answer from all these. Thank you so much. So before we'll take up the question, we have a last presentation, Dr. Madan Jayaraman from Chennai, evidence-based comparative analysis between PRP and PRF. So I think there are still few questions which are left unanswered, will be answered by Dr. Madan soon. Dr. Madan, will you share your slides? Dr. Madan, are you here?
Hello, Dr. Madan. I think it's
Dr. Madan,
I'm sharing my
you-
screen, sir.
you-
Yes, I'm here. I'm here.
We can't see you, so we thought
Okay.
maybe there is
Sorry.
something. No problem.
No. Yes, sir. Good evening, one and all. And I thank to present on a topic evidence-based analysis. The previous speakers have spoken about PRP. What are the contents? How do we prepare all those things? Basically, platelet products. There are two generations. First gen PRF, and the first generation comes in the form of PRPs are prepared use, and the second can use. What are the evidences available? That is what we are going to see today. As already Dr. has explained what is the about the baseline of platelets in the plasma is physiological role in the form of growth factors. So how do we prepare? Usually we do prepare with the manually we do prepare in a double centrifuge with anticoagulant, mainly calcium we used to take in a sodium citrate tube or EDTA, or centrifuge it for the RPM and time depends upon each and every surgeons what they are using. How in literature they have been mentioned, it is a soft spin and hard spin. Soft spin should touch up to 3000 RPM. The gravity, based on the gravity, we have to keep the first centrifugation. We used to get a column like RBCs. So we have to collect the buffy coat layer and we have to centrifuge it. We will get the resultant column will be this PPP and PRP. That is, top 2/3 will be PPP and bottom 1/3 will be PRP. This PRP, we can, lot of literatures have been mentioned, activation without activation. So various analysis, that meta-analysis and systematic reviews have mentioned that with activation or without activation, both have given the same results, the functional results. So this is regarding platelet-rich plasma. The second one is platelet-rich fibrin. This is the second generation of platelet product where anticoagulant and some don't centrifuge within coagulate and we don't get that platelet rich fibrin gel. So at the end of first centrifugation, you should do, there will be we can, so this is how it looks like. Top 2/3 will be that gel, that plasma gel, in where we have to cut that first half. First top half we have to discard. It can be PPP. So we have to concentrate only between the layer between this RBC and PPP. This is platelet rich fibrin gel. That is what indicated in orange color. This we can take and we can keep it for any ulcers or anything. There are little modifications in PRF. I'll deal it in the later. So what are the differences between first generation and second generation platelets? In first generation platelets, growth factors present is smaller when compared to the second generation of platelet products, that is platelet rich fibrin gel and leukocyte rich platelet rich fibrin and advanced platelet rich fibrin. All these have considerable amount of growth factors. And regarding regenerative capacity of bone and soft tissues, for soft tissues, yes, PRP is better, but for harder tissues like bone, yes, we have to go for PRF. The reason behind the usage of PRF is PRF acts as a scaffold where it holds the growth factors in one single place and it will elute the growth factors at a constant interval so that there will be continuous regeneration of that particular area. So these are the main differences between first generation and second generation platelet products. So there are modifications of PRF, that is APRF, APRF plus, injectable PRF and titanium PRF. These all differs by rotations per minute and for how many minutes we are going to keep the tubes for centrifugation. So the ideal injectable PRF, we can directly inject into the bone or soft of interest, that is 700 RPM for 3 minutes in plastic tubes will do wonder for injectable PRF. But if you want a titanium PRF, titanium history, they use for 2800 RPM for 12 minutes in the medical graded titanium tubes. These tubes will be coated with titanium. This will activate platelets and it will form a gel which will hold that micromolecules, that is cytokines and growth factors, and elute in the particular area. So these two things are highly advanced form of PRF. So let us see some evidences, the level 1 and level 2 evidences for each and every indication which we are commonly seeing in orthopedic practice. The level 1 evidence, that is network meta-analysis for lateral epicondylitis, that is tennis elbow. Here, what we have concluded is PRP offers a significant pain relief therapeutic agent when compared to saline control, and there won't be without any improvement in functional outcome of that elbow movements. But there are very low quality evidence for concluding the network meta-analysis, but still we would tell that PRP is the most promising therapy for lateral epicondylitis. But for the functional movement of elbow, we need further more details and further more large scale RCTs to conclude, yes, that PRP is the modality for lateral epicondylitis. Otherwise also, PRP has offered a greater pain relief in terms of lateral epicondylitis when compared with other controls, that is saline control. The second one, comparing leukocyte poor and leukocyte rich PRP in management of epicondylitis. Here we have compared both the techniques and we have drawn the conclusion for the level 1, and we have given level 1 evidence that PRP is a safe and effective treatment option for lateral epicondylitis pain and functional score with both the type of PRP. Here, leukocyte rich and leukocyte poor both have given similar results. We have analyzed us whether platelet rich plasma is effective in spinal fusion. Yes, it is recommended for fusion, but the role is very, very minimal. There is a paucity in the fusion role of PRP. So still furthermore, furthermore studies have to be done and for proving that PRP is helpful in spinal fusion. Now also there is a fusion, but it acts as an adjuvant. It is not the main modality for fusing the spinal fusion. The next indication what we have taken is lumbar disc disease, whether PRP has any role. Yes, there is a limited role in controlling the pain of the lumbar disc, but there is no any improvement and structural and functional improvement of the studies which have been included. Here totally 12 studies have been included, which are recently published in 2020 and 2021, and we have analyzed in 2021. Then we recommended that there is some beneficial role in pain relief, but there is no structural or functional outcome in the included studies. So we recommended large-scale double-blinded RCTs to analyze the further benefits for this particular modality of treatment in lumbar disc disease. Then we investigated autologous platelet rich plasma in delayed union of fractures. Yes, there is a good role, unless otherwise it is the other hindrances for delayed union is ruled out. So autologous PRP might be management of delayed union of long bone fractures. Yes, here delayed union we have taken as after 12 weeks. After 12th week of, either surgical management, after 12 weeks, when the fracture is not getting united, then it was taken as delayed union. But here there was no other modality has been compared. Still, we would recommend that comparative studies are needed further to validate the results of that particular study. Yeah, these are all the evidences which we are showing here. Distal femur locked with a distal femoral nail, retrograde nail, which was operated, and after 4 months it was not showing any union. So we have been each dose has been given at a 3-weekly interval, and we have followed it up for 1 year. And DEF3 images, which shows proximal tibia fracture delayed union by 3 months post fixation, which has been followed for 12 months. 12 weeks, that is 3 more months. And under image guidance, we have given 3 doses of PRP at 3-weekly interval, which showed a good functional outcome at the end of 12th month. Then the next very good indication is knee osteoarthritis for PRP. There are a lot of meta-analysis which has come across in 2021 and 22. They have mentioned that effect of platelet concentrate goes beyond its mere placebo effect, and PRP injection provide better results than other injectable options, whether it is prolotherapy or sucrose or any other injections or steroids. PRP offers the best pain relief, and the benefit increases over time. The clinical benefit was seen significantly after 6 to 12 months, but still there was a substantial good improvement. The improvement remains partial and supported by low level of evidence. Hence, further study and further research has to be done for the benefits and to identify the best formulation, whether leukocyte depleted or leukocyte rich PRP have to be used, or injectable PRF has to be used for ONE. So the one more study, intra-articular PRP, this is also a meta-analysis, that level 1 evidence they have given. So what they have told is intra-articular PRP injections produce superior outcome when compared with corticosteroid injections for symptomatic management of ONE, which include pain management, less joint stiffness, and better participation in sporting activities at 12th month follow-up. So what they have concluded, one more conclusion, that 3 intra-articular injections separated by a weekly interval is more effective than 1 intra-articular injection for ONE. Then there are one more meta-analysis of RCTs, which has compared PRP versus hyaluronic acid for ONE. So patients underwent treatment for ONE with PRP has been expected to experience the improved clinical benefits than hyaluronic acid. They have given a consensus that leukocyte poor PRP may be a superior line of treatment than leukocyte rich PRP. And for this statement, further studies have to be proven and a network meta-analysis have to be done. For this, network meta-analysis work is already taken up by Indian Stem Cell Study Group, and it is ongoing. And we will be soon giving the consensus in 6 months to 1 year time. The next one is PRF, that is platelet-rich fibrin, which is a have compared platelet-rich.
Then can you wind off little?
Membrane, though it is yes, sir. Another two more.
Yeah.
It contains stem cells, but still PRF wound has shown better wound healing than amniotic membrane here. So one more study has been done by us for management of non-healing ulcers by autologous platelet-rich fibrin, which has at the end of 4th month there was 100% precision in ulcer area, and the volume also has been improved. The VAS score improved, and the pain reduction of pain was due to anti-inflammatory property. So we have concluded that platelet-rich fibrin gel is the biological treatment for non-healing ulcers by decreasing the morbidity and improving the functional quality of life. So these are the clinical images. This is the undersurface of the foot. First one. The second one images over the medial malleolus, and the last one is a ball of great toe. All have shown good improvement at the end of 4 months. So the take-home message here is platelet-rich plasma holds good and a better therapeutic option for tendinopathies, knee osteoarthritis, and rotator cuff tears, whereas low evidences are available for spinal fusion and lumbar disc disease. And platelet-rich fibrin holds very good for non-healing ulcers. So for both this modality, further large-scale trials and meta-analysis have to be conducted to document either PRF or PRP to be the therapeutic option for particular indications. Thank you.
Thank you so much, Dr. Madan, for a wonderful, enriching presentation. Thank you so much. Now I'll request Professor Sandeep Shrivastava. We have come to end of the session for having any comments, for giving any inputs, and then we'll go for the question answers.
Very good evening to you all. Thank you, Manish, Khanna sir. It was a fantastic session on orthobiologics, and at the outset itself, I should congratulate all the officials of IOA, including the President, Honorable Dr. Ramesh Sen, for organizing this. We started with the role of orthobiologics of Professor Khanna. We all know, and it's my favorite sentence, the 21st century belongs to biologics. Biologics, along with technology, will change the face of the front of all the problems for which we have not yet found the solutions. As it was so much evidenced by the next lecture by Dr. Mahapatra, where we saw that the arterial ulcerations, which were unanswered till yesterday, now we are finding that there is an indication for putting the orthobiologics to use and getting something useful out of them. Similarly, Dr. Ravi had put up a very nice presentations detailing about the properties of PRP, why and how it works, and what it has in store to say that scientifically, the PRP, particularly through its properties, as you said, it's a store of pharmacy, will work towards proliferative healing. It's a very different concept, which is getting built up from inflammatory healing to proliferative healing. And the angiogenesis with the help of growth factor which triggers all this is probably, as was also emphasized by Manish Khanna sir, that how Elizarov, under the controlled stress, led to angiogenesis. Similarly, here is another way where growth factors can also lead to controlled angiogenesis. So probably once all these principles get combined, we'll have answer to many diseases, many problems for which we are seeking solution. It's very exciting. It's exciting particularly for all the youngsters to build more evidences. And Madan have done a wonderful work to bring out evidences which are getting more and more, saying that it is no more a null hypothesis which is rejected. It is a superior hypothesis which is getting established. So our orthobiologics, particularly PRP, is showing evidences that it works. And it works in many situations, as has been evidenced by the different literature as put out by Madan. And also, Madan, it's very good that you have put up the evidence for PRF working. And I agree with you that PRF is good thing, particularly for small or non-healing ulcers. But yes, one limitation is we cannot put PRF on a very big wounds. It takes a lot of blood to make a PRF out of for such wounds. But PRF is very easy and a very convincing way of treating wounds, particularly for non-healing diabetic ulcers, small wounds, which later on lead to big problems, even amputations. So thank you, Manish sir. for a very nice
So
session.
much.
And it has been a pleasure watching all these youngsters, including the senior officials of Orthobiologics Society, ISCG, participating so eagerly and wanting to change the face of orthopedics. Thank you, sir.
Thank you so much. Thank you so much, Professor Shrivastava, for your nice comments. I have a question for Dr. Madan, actually. So, a very wonderful lecture for PRF. And as you have already told, that PRF is a better modality as far as the bony fractures are being considered. But I just want to know how you are going to make a PRF to be injected in a delayed urine site under image intensifier whenever it is being required.
Sir, regarding bone union, that is delayed union or non-union, we can use injectable PRF. Injectable PRF.
Injectable. So you have, Dr. Ravi, can you mute your, let me do myself. Dr. Ravi, can you mute yourself? Dr. Ravi.
Ravi, sir, can you please mute yourself?
I'll do it.
Yes, sir, he is on mute.
So see, you have, how you are preparing injectable PRF?
Sir, we have to use in a low centrifugation speed, that is 700 RPM for 3 minutes. So that will give you a injectable PRF. It won't be a fully jelly molecule. It will be very, how to say, it will be thick. That's all. So you can inject it very faster. That study is ongoing, sir, yet to publish that results. Once that, study is completed, I'll be showing you that injectable PRF in delayed union, not in non-union, sir. We are using in delayed union actually.
Because as of now,
PRP is the best PRP. Injectable PRP, that is liquid PRP, is very best for all the indications except wound healing. We can use PRF. That is also small ulcers. Actually, as Shrivastava sir has told.
Yeah, in fact, I feel like even in a wound healing, you never know how much depth of the wound is actually. So for me, actually, it will be a better PRP, because in that case, we can go deep down to the different levels at an area actually, because definitely at the end of the day, the single visit of a patient matters in giving the results. Welcoming Dr. Chinmoy Das sir. Yeah, definitely we can do it. Welcoming Dr. Kanchan Mishra, our secretary, is also here.
I have one question, Dr. Madan.
Yeah, Dr. Kanchan, please.
Can I?
Yes, sir, please.
Okay. Yeah, Madan, you saw the good data of the evidence-based support of the PRP, and also there's a many paper, they have the result of the PRP. Some say it's okay, some say they're not working fine. But I think the main problem is because due to heterogeneity of the PRP formulation, because we don't know how they are going to make the PRP. Like you make some other way, I make some other way. The definitely result will be different way, right?
Sir.
So one thing, so if we have the international one SOP for the PRP or internationally and national, then we can compare the result. We can say that this will working or this will not working. So this is a very big problem, heterogeneity PRP formulation, I think.
Sir, we can draw down a protocol, like after doing a network meta-analysis on how to prepare PRP, what are all the best modality. After that, we can give one SOP, sir. But to do a network meta-analysis, it will take minimum 6 months to 1 year, sir.
Yeah. That's
we
good.
Can
nice.
Already one thing has been initiated, sir, as Professor Khanna sir has told, for ONE how to go about that. Sir has given this ideology last year. It has been initiated. It is ongoing. It will take 6 more months to complete. So the same way we can take the consensus for PRP, how much ml, what is the centrifugation speed, time, everything we can consider for all the indications like soft tissue and bone indications. Both the indications we can prepare one network meta-analysis and we can give SOPs. In that way, it will be helpful, sir.
Yeah, SOPs can only be given once we are ready with all the trials and everything, because only in that basis we can form a protocol. That was the thing which we were discussing in the meeting last time. Thank you so much.
Yeah.
So, Dr. Das, we welcome you, and we miss your, I think he is traveling. We are not able to be. Anyways, so we have some questions on the board, but I think we'll take up in the end. Coming to the session B, unfortunately, Dr. Manoj, he's
Thank you, Professor Khanna. And
Dr. Das, please, please have your.
I'm very sorry I couldn't. Yeah, I'm very sorry I couldn't connect with you people before because of some engagement which came up in the last minute. Actually, last night, 1:30 a.m. So the CM office called and we had a meeting. So I had to be there. So, but now.
Thank you so much. At least you are here now for.
Yeah.
So
yes,
now with your
sir.
permission, we'll go to the session B.
Yes,
and Dr.
Yes.
Manoj, he is not able to join. So I have just tried out to take out something from my laptop regarding the regulatory issues, and we'll want to share it here with your all kind permission.
Yes, sure, sir. Go ahead.
Well, regulatory aspects for the stem cell users is very important as far as the clinical practice of orthobiologics is being considered in India. Stem cells, cell-based products are regulated as drugs now. Mind it, the stem cells and cell-based products, as per the new Drug and Clinical Trials Rule 2019. Well, importance of stem cell research been started and been propagated by lots of legends since many decades, and around the globe, definitely different places, there are different conditions, different rules and regulations. Very liberal policies on the research are there in Great Britain, where the therapeutic cloning is being allowed, so they are a little ahead than us. And stem cell research has been allowed, which has also been here in our country. France is having less liberal policies, and uses of excess embryos from IVF has been allowed. That's a good part. Germany, on the other hand, had a very strict policy. So as far as our country has been considered, we try to find out and to utilize the guidelines given by ICMR. And according to that, it is if it is a minimally manipulated cell. So what we are discussing right now for the last 1 hour is minimally manipulated cells. And of course, we are talking about the Bmac. So for minimally manipulated cells, it has to be used for a non-homologous purpose. In that case, you have to have a approval from CDSCO or Cellular Biology-Based Therapeutic Drug Evaluation Committee. But the Central Drug Standard Control Organization has got a lot of role in recommending it. For example, if you're using a bone marrow or a peripheral blood or even umbilical cord blood-derived mononuclear cells or bone marrow concentrate by any device for any route of administration other than intravenous, then for the neurological musculoskeletal condition, then you have to take the approval. That is a very important thing. But at the same time, I will say that if the cells and tissue are being removed and implanted to the same individual during the same surgical setting, in the same OT, in a single setting time, with a minimal manipulation being done, then it can be, it's a debatable topic, not to comment right now here, but definitely the clinical trials which are being there, and I missed many of the clinical trials which was being given by Dr. Ravi for our legends of the country. So still a lot of clinical trials have been done, which are being done after the regulation has been taken from CDSCO and the National Ethics Committee. Of course, the Institutional Ethics Committee, Institutional Stem Cell Committee is important to take into account, but regulatory pathway has to be followed for the stem cells or the derived products in which the applicant have to apply for the clinical trials, as for the format of the CDSCO. And if it has been verified by them, then they may come to visit. And unless and until this has been attached to a GMP certified lab, it will not going to work again. Proposal once has been discussed and finalized by the Stem Cell Apex Committee, then is being regulated and NOC has been granted, and then one can go for the phase 1, 2, and 3 trials. These trials are being done in India, and in the end of the slide, I'll be able to reach to that part also. But the most important thing is clinical trial using the cell. I'll again say, when they're using the cells which have gone more than a minimal manipulation, for example, even if a culturing of 24 hours, then they require a CDSCO or Cellular Biology Based Therapeutic Drug Evaluation Committee clearance. Of course, along with the Institutional Stem Cells Committee and Institutional Ethics Committee clearance. That is good also for many reasons. Evidence-based application, which we are discussing since evening, still has got good evidence, but at the same time, some solid scientific evidence is missing. Just a few minutes back, we were discussing that, look, once we have a good evidence for a PRF, if it is better than PRP for a bony delayed union, then we'll go for it. So evidence has to be generated. Evidence to be generated means the person or the institute has to go for the clinical trials along with all these regulatory pathways. But as of now, only the hematopoietic stem cell for the hematological diseases is being approved as a stem cell transplantation, which has been there in the annexer also. It's not possible for me to go for the details. But the commercial use of stem cells as an element of therapy is prohibited to some extent, to be emphasized if it is outside the purview of a clinical trial. And of course, it should not be tried. When we are discussing about the level of evidence, so it is not always very important that if you are doing a clinical trial, then only you can contribute. It's not like that. Even the level 1 evidence, which means you can have a randomized controlled trial. Okay, fine. If you can go for it, it's good. Otherwise, you can have a systemic review. So I'll always have appeal to the young orthopedic surgeons to go for a systemic review analysis for generating the level 1 evidences, so that at least we can move ahead in which way to go. And the type for publication, which is important, is original research work, which everybody wants to share, review article, clinical trial, which is having a regulatory part, or the systemic reviews or meta-analysis, which is not a very big deal. And even, for the persons who are promoting from assistant to associate professor in an institute, they can go for original papers or even a meta-analysis that is approved by NMC. So that's again a good thing. Last year, we had an international conference at Raipur where we tried to bring out a white paper, which has been sent to DCGI. It is under evaluation right now, in which we tried to have a general consensus of ours, of association, on the different level 1 evidences, which was been created. So such type of thing is needed from our part so as to promote the research work. So clinical trial using allogenic stem cells with any degree of manipulation or using an autologous stem cell with more than manipulation or major manipulation needs a regulation. At present in India, with the Cipla, Cipla is marketing a Stempeutic product, which is a allogenic, but still it has been processed into different proper way of evidences from level 1 to 2. All the research work has been done, and it is in the market. Similarly, Osgro is there for the bone cell therapy, but these are a costly initiative, costly process, because the cost has been involved. Until we are able to reach to a point when the stem cells or the regenerative cells can be of some use for a common orthopedic surgeon at a district level, I think the job has not been done. But we need to work up all together under the regulatory pathways for promoting this thing, and we should try for going for any clinical trial if it is possible, specifically starting from phase 1 in India. For any drug products, it is starting from phase 1 to be done. So thus the therapeutic use of stem cells other than approved hematological disease should be treated as investigational in a trial manner, conducted in the form of clinical trial after having regulatory issues. Definitely ICMR guidelines and other guidelines are very important, and if we go against that, it is actually a little bit of unethical, though I will say in India still there is no clear law about the regulatory aspect, but definitely it will be soon coming into it with all the input which is being given by the regulatory bodies and with the work, clinical trials being done in different fields. In the textbook of orthopedic rheumatology, we have written a chapter about the ethical concerns about the stem cell regulatory aspects. So those who have got this book, they can go through that also. Thank you for patient hearing. So now I'll request for any comments on this from Dr. Kanchan Mishra, Professor Shrivastava, our president, Dr. Ramesh Sen, before we move to the...
Yeah, Dr. Yes, Dr. Manish is very important thing you have told us. It's a very important for us to know regulatory thing. That's a very good minimum manipulation, maximum manipulation. It's very important. What is the minimum manipulation and what is the maximum manipulation? And one thing also would like to tell, in I think whole world they don't have PRP guidelines, PRP regulatory by FDA. Only Dubai have PRP SOP, and Dubai used to give the license for the PRP. If you want to make the PRP, you have to get the license from Dubai government. But the whole world, including India, they don't have any license like structure. I think that we can apply for the PRP. It's offline, going on. That thing. But thank you, Dr. Manish. Thank you very much. It's nice to see you.
Thank you so much. Thank you so much. So now we'll request our last presentation, which is from Dr. Shubham Bharadwaj.
Sir, I would just like to add that
whenever
we are talking about the regulations, we should repeatedly inform all the viewers that India is the first and only country which has got already approved 2 cellular therapy indications. One is the critical limb ischemia and other is the osteoarthritis, for which the company Alchem will be coming out with a product within 1 or 2 months. But the product is already approved. And as I said, the third product is for Crohn's disease in unhealed recurrent fistula in ano. So the scenario which we should project to all the Indian doctors is that India is leading in this field of regenerative medicine, and already stem cell therapy is approved in India. In short, if I want to convey a message after this talk, the message is stem cell therapy is approved in India. That's all. Thank you.
That's good. Thank you.
Well, Dr. Ravi, it is a very vast discussion, and at this level, we can't go for it more. But definitely, it has got an approval, but to a limited extent, and under the regulatory pathway, we have to work it up. But definitely in the Helsinki Declaration, if there are certain conditions in which you have to go for it in the benefit of the patient's interest, it should be done. It is being done. But definitely, we are ahead from others as already products are available. But and we are seeing with the interest when it will be done with the regulatory work into it, so that it should be used for a common man, for a common general person who don't want to invest, who don't have money to invest actually into it. Thank you so much. So I'll request Dr. Shubham for his paper on platelet-rich plasma in periarthritis shoulder, a comparative analysis with suprascapular nerve block. Over to Dr. Shubham Bharadwaj from PGI Chandigarh. I'm sorry, PGI Raipur. Sorry.
Good evening, sir. Good evening, everyone. So I'm Shubham Bharadwaj. I'm a postgraduate junior resident at AIIMS Raipur. So I will be presenting my paper on management of periarthritis shoulder by suprascapular nerve block versus platelet-rich plasma. So it has already been pointed out.
Dr. Shubham, can you open your camera if there is no issue for the signals?
Okay, sir. Sure.
Yeah, fine. Please.
So, introducing the topic, so periarthritis of shoulder is a very common condition with an incidence of around 3 to 5% in the general population. And as we all know that India is the diabetes capital of the world with around 9 to 11% of the population suffering from it. And the periarthritis shoulder increases its prevalence when we talk about the diabetic population at around 20%. So as far as we can talk about India, so India forms a very big chunk of the patients of periarthritis capsulitis of the shoulder, and it is characterized by painful and global restriction of active and passive glenohumeral range of motion, most notably the abduction and external rotation that we all know. And consultations to general practice in general are around 2.4 per 1,000 people per year. So it's a common condition that a patient presents within an orthopedic OPD. 1 second. Yeah, so generally it affects females more than males and at age around 40 to 60 years. And diabetes is the most common associated disorder, followed by thyroid disorders, other neuropathies. So, and patients might have a history of myocardial infarction or a cervical spine disease as well. Talking about the pathology and the clinical features of the disease. So generally patients go through the clinical stages of synovitis, freezing, then the shoulder is frozen. That is when the patients generally present to us. And then the disease is self-limited inflammatory, and there's a stage of thawing. So inflammation in and around the joint capsule leads to stiffness, pain, and capsular fibrosis in case of adhesive capsulitis. And mainly the inflammatory markers like TNF-alpha, interleukin-1, and interleukin-6 are known to appear both in the glenohumeral and subacromial bursal region and lead to the extensive inflammation there, and following which there is a stage wherein there is an formation of adhesion all around the capsule joint capsule, which leads to restriction of the movement. The fibroblast and myofibroblast with abundant type 3 collagen deposition is also seen in the coracohumeral ligament and the rotator interval capsule, which is also somehow responsible for the restriction of the movement that is there. And then there is what else is observed is the absence of multiplication that is seen in the superficial synovial layers in the shoulder joint at the time of adhesive capsulitis. So there are multiple treatment options that an orthopedic surgeon has whenever a patient comes to him or her with a adhesive capsulitis. So mainly these consist of non-steroidal anti-inflammatory drugs, which generally form the first line of treatment. Then there are options for intra-articular steroid injections, suprascapular nerve block, intra-articular platelet rich plasma injection, and whenever the pain, the amount of pain that the patient has, if it permits manipulation, we can go for it. Otherwise, manipulation under general anesthesia, and in severe cases, we can go for an arthroscopic capsular release for the patient to have a range of motion given back to him or her. So what is the role of suprascapular nerve block? The suprascapular nerve, as we all know, is a mixed nerve which originates from the upper trunk of the brachial plexus, from the C5, C6 nerve roots. And some people do have a C4 component as well. And it provides around 70% of the sensory supply to the shoulder capsule. Okay, so it is mainly the nerve that is responsible for the pain sensations that come from the shoulder joint. And the main thing that that inhibits the rehabilitation of a patient with adhesive capsulitis is the pain component that is there. So if we somehow block this nerve, the signals from this nerve, so the pain tolerance of the patient is increased, and the patient can go on into rehabilitative physical therapy, which can lead to a regain of the motion of the shoulder joint in case of an adhesive capsulitis. And when we talk about the role of PRP injection, so whenever we give an intra-articular PRP injection in the glenohumeral joint, there occurs a degranulation of the platelets that releases the growth factors. These growth factors like PDGF and TGF-beta then are transformed into their bioactive state by the addition of histones and carbohydrate side chains. And these active proteins then bind to the transmembrane receptors of the target cells, which include the mesenchymal stem cells, osteoblasts, fibroblasts, endothelial cells, and epidermises that are there inside the joint. And these bioactive molecules that exist within PRP have profound effect on inflammatory, proliferative, and remodeling phases of the wound healing, thereby altering the natural disease process and leading more towards healing than scarring. So what we went ahead with, the hypothesis is that we went ahead with an alternate hypothesis, and we thought that we proposed that an intra-articular PRP injection is a better modality for the treatment of suprascapular nerve block in the management of periarthritis of the shoulder. And the aims and objectives of the study were to evaluate and compare the outcome of periarthritis shoulder after either injection of the platelet rich plasma or the suprascapular nerve block. So our study design was a prospective randomized parallel group active control trial study, and the place of study was our department only at AIIMS Raipur, where the patients were treated on an outpatient department basis. The study was carried out for a period of 1 year, and the sample size was of 90, 45 in each group. So these are the inclusion-exclusion criteria that we worked with. So the inclusion criteria with the pain and stiffness in one or both the shoulders for at least 4 weeks, along with that restricted active and passive range of motion at the glenohumeral joint, age more than or equal to 40 years and less than 60, patients giving voluntary consent for participation in the study with normal X-ray of the shoulder in the AP view. The exclusion criteria was age less than 40 and more than 60. The patients with chronic shoulder pain due to other causes like nerve damage or neurological disorders, patients having any skin problems including trauma, infection over the affected shoulder, and history of fracture around the shoulder joint, patient following shoulder surgery, or uncontrolled diabetes, allergy to any product of tipomethylprednisolone. These patients were excluded from the study. So how did we form the group and did the randomization? So patients attending the orthopedic OPD at AIIMS Raipur satisfying the inclusion and exclusion criteria were used to form the groups. A computer-generated random number allocation was used to form the 2 groups. So group A, we named it as the suprascapular nerve block group, and the group B will be the patients who received the intra-articular PRP injection. So talking about the suprascapular nerve block, so patients were made to sit in a position with elbow flexed at 90 degree. So a line was drawn along the length of the spine of the scapula. This is bisected by a vertical line drawn from the angle of the scapula, dividing the scapula into two quadrants. And then localizing that particular area even more specific with an ultrasound probe, we use 2 ml of 2% lignocaine injection for the purpose of local anesthesia, and a mixture of 9 ml of 2% lignocaine and 1 ml of 40 milligram of dipomedrol was used for the suprascapular nerve block. And similar for the technique for the PRP administration and preparation and administration. So 35 ml of blood, around 35 to 40 ml of blood was drawn from the peripheral vein of the patient undergoing this procedure, and centrifugation followed by Buffy coat based platelet rich plasma was harvested. So PRP containing approximately 7.5 lakh platelets and 4 ml of the blood product was used. So the landmark of injection was 2 to 3 centimeter inferior, 1 centimeter medial to the posterior lateral corner of the acromion process and directed anteriorly in the direction of the coracoid process, and the nasal position was always confirmed under the CM guidance, and a PRP was injected into the joint. Following these injections and the nerve blocks, the follow-up of the suprascapular nerve or platelet rich plasma patients were instructed for a home-based 10-minute shoulder range of motion exercise thrice daily, and were evaluated on day 3 and 1 month as per the constant and Morley shoulder score parameters. So this was our case record form that we used to record the data that was there from the patients. And so these are the photographs that were taken on the day 0 and at the end of 1 month from a patient who had undergone a suprascapular nerve block for adhesive capsulitis. And these are the pictures taken for a patient who had undergone a PRP injection, intra-articular PRP injection for adhesive capsulitis at day 0 and in first month. So talking about the scoring that we used, the constant and Morley score was used. So talking about its scores in the group A suprascapular nerve block group. So we can see the scores of pain, activity, arm position, strength of the abduction and flexion, and rotatory movements at day 0, day 3, and day 1. So there's a constant increase in the scores regarding the pain, activity, arm position, and all the movements. So it denotes that the patient's functions had improved during the course of the treatment. Similarly, if we talk about the scores in the PRP group, so we can see that there has been a gradual increase in the range of motion, but the pain scores were sort of decreased in the 3rd day itself, and at 1 month though they had decreased sharply. They had increased. So it shows that the patients had a pain worsening at the day 3 of the treatment in the PRP group, whereas there was an improvement in the pain at day 3 in the case of the suprascapular nerve block. Now, if we talk about the mean and the standard deviation of these two groups injection at the day 3, so this was these were the results, and then at the 1 month, so we can see that PRP suprascapular nerve block performed better than PRP at day 3, whereas PRP at the end of 1 month had better results compared to suprascapular nerve block. So talking about the results and the interpretation, so both the suprascapular nerve block and PRP injection showed statistically significant improvement in all the parameters of the score at the end of 1 month, but at the day 3 follow-up of the suprascapular nerve block showed significant improvement. At day 3 in patients receiving PRP, it was found that due to inflammatory phase of the active proteins, the pain increased significantly, causing more restriction of the movements as compared to the initial stage. But at the 1 month follow-up, PRP showed more improvement in the functional outcome than suprascapular nerve block, but statistically it was found to be insignificant when compared to suprascapular nerve block. But yes, more than the initial disease process that was there. So our study found out that yes, actually we were comparing oranges with apples. But the thing is, the oranges, if we compare suprascapular nerve block to the orange, so they have resulted in a decrease in the pain and improvement in the motion in the initial time of the disease, but the PRP improved the overall functional outcome at the end. So acutely, if we have to give pain relief to the patient, we can use oranges, or we can see the suprascapular nerve block, or if in the long-term process, if we have to treat the cause, the basic root cause of the disease, the degenerative changes that occur in case of the scarring that occurs in case of the disease, so PRP will be better for those situations. So we recommend the management of periarthritis of the shoulder with suprascapular nerve block in acute stages, and then we can couple it with platelet-rich plasma, so that we overall give a very good result to the patient in the acute phase as well as in long term. Thank you.
Thank you so much, Dr. Shubham, for a very nice presentation. Definitely, as you have already compared oranges with the apple, definitely PRP has got a good role, but provided PRP in a periarthritis shoulder should be worked up, whether the patient is diabetic, whether any hyperuricemia, there are other causes are there, which you have already been ruled out in your study.
Yes,
so
sir.
this is a wonderful work being done at AIMS Raipur. Thank you so much. I'll congratulate you and the team for this work. Thank you so much. So now we are coming to end. We are already behind the schedule. We have only a few questions there. Although Dr. Shrivastava has already answered, but there's one question by Ravi, Dr. Ravi, that diagnosing stage 2 and stage 3 AVN and going for a core decompression, and later on with the IV use of cytokine growth factor has got any role? So definitely IV growth factor later on does not have got any role in using it. And further, he want to ask that if with the core decompression being done, then Bmac can be done again within a year time if it's want to be repeated. So we don't have any evidence for that. If it works very well, it works very well depending upon the grade of the disease. If it is a grade 1, early grade, definitely with the Bmac and the core decompression and other parameters, it works well. We don't have any data for that, and I don't feel there is any requirement for the patient to go for another core decompression plus another trial for any injecting any Bmac and that site, because after 6 months that site, the compressed site will already be closed actually. Thank you so much. So any questions from the faculty here for Dr. Shubham? Any comments?
Yeah,
Yes, sir,
I have one. Yeah, Dr. Shubham, it has been seen. I went through some studies with comparing this suprascapular nerve block with your PRP injections.
Yes, sir.
So they concluded that PRP is much better, and in the long run, no doubt you have also concluded the same thing.
Yes, sir.
But how often you give the suprascapular nerve block? Means what is the how often do you give it? Frequency?
So if we talk about frequency, so generally the patients, when they come in the acute phase of the disease with significant amount of pain in the OPD, and they're crying out of the pain and they're unable to do even their activities of daily living because of the global restriction of the shoulder movements. So in those cases, we generally give the patients an injection of suprascapular nerve block, considering if there is no any contraindication as such or uncontrolled diabetes. So we make these patients undergo suprascapular nerve block on a very routine basis, but if the patient out of the study, but if the patient generally comes with somehow milder form of the disease, and where we can afford for the patient to undergo a phase of inflammation and then an overall improvement of the disease, we go for a PRP injection nowadays after the study that was conducted in our department. Sir.
No, I mean to ask you that.
Hello.
How often do you repeat the injections?
So how often? Generally, the injection that we give, the suprascapular nerve block injection that we give, it is very much effective for a period of around 3 to 4.
Just give one injection.
Yes, sir. We hardly have to repeat the injection because generally the patient.
How often do you?
Hello. So
Dr.
generally.
Shubham wants to ask how oftenly you are required to repeat the PRP in a particular case.
Sir, in my life, I don't think I have repeated the suprascapular nerve block in any of the patients. Like one injection was more than enough to have the patient go back to the rehabilitative phase and get all the movements back, and the disease used to be controlled. So generally, because the ulcerative vasculitis in itself is a self-limiting disease, so generally patients, even just after one injection, they are very much able to go back into the mainstream and do the physical therapy and then have their movements back. So in general, we don't repeat these injections very frequently compared to the other nerve blocks like we gave in the case of radiculopathy of the spine and all, where we repeated at 6 months or 7 or 5 months. But we don't repeat suprascapular nerve block as such because the patients generally rehabilitate back. Opposite side, yes, we give if the patient has the adhesive capsulitis of the opposite side, but the same side, we hardly require to repeat the injections.
Okay. And whether you have tried this thing cocktail regime, that clonidine nowadays the NSAIDs people they give clonidine with lidocaine. Have you tried that?
No, sir. We haven't tried it yet. I know about the cocktail regimen, the clonidine and lignocaine and penicillin and all, but so we haven't tried it in
No,
our center.
only lignocaine.
Yes, sir, lignocaine and dipamidol. We have only done that.
Okay. Okay. Thank you, Dr. Shubham.
Thank you, sir. Thank you so much.
Dr. Shubham, please stop sharing your screen. So finally, we are coming to the end of this 1 hour program extended to 2 hours. I'm highly thankful to everybody on dais, and I'll now request our Secretary General of Indian Stem Cell Study Group, Dr. Kanchan Mishra, and Professor Shrivastava Mahapatra, sir, who is the ex-president, past president now, for giving their valuable comments before we wind off this session. Over to Dr. Kanchan Mishra.
Thank you, Dr. Manish. Really, it was very fruitful webinar, and many people have benefited definitely by this lectures. And thank you, Dr. Manish, for your lecture, Dr. Madan, Dr. Ravi, and Dr. Mahapatra. Really, all lectures are very important, very informative. Even like Dr. Ravi say, 1 million per microliter PRP is better for the. So that is a really very wonderful session. And would like to thank to all speaker and Dr. Manish. I request you please continue this type of webinar. It's a very informative, very informative. You have a lot of work. I know you are very busy and very responsibility on your shoulder. But really, I'm very appreciate. I'm very happy to keep you. We are behind you, and I'm very happy because you are 100% involved in this. You are very good academic as well as clinician. Thank you so much. Thank you, Dr. Manish.
Thank you so much. Over to our past president, Professor Mahapatra, sir. Sir, your voice is muted. So your mic is muted, sir.
Yes, sir. Thank you very much, Professor Manish, for giving me the opportunity to share my experience of cell therapy in peripheral vascular disease. As you know, I have presented my experience in different forums, both national and international level, with appreciation. And you will be surprised to know one of those colleagues who were very suspicious of this, suspicious, or they were speculative that this is working or not. Now they are approaching me, and one of my colleagues asked where I will get best treatment for osteoarthritis of his wife. I told, go to Professor Ravi in Trichy. And indeed he went and took a therapy and returned. And last week he gave me a party in the nearby restaurant because he got some benefit.
Definitely.
Because Dr. Ravi is there. I'm not telling lies. This is the truth. Dr. Ravi gave the PRP to my colleague's wife, and he went from Burla to Trichy and took the treatment and now benefited. And partially benefited, not fully 100. So I think he was going. So this is working, and the consciousness is spreading that cell therapy and platelet-rich plasma or platelet-rich factors are working, and scientists and doctors and professors are accepting textbooks. It has published already. You have published textbook, and regenerative medicine chapter has come in Valiant Love Surgery, in Harrison textbook of surgery. And as Dr. Ravi told, it is accepted in India, but the world is going to accept it. I must congratulate you as a founder and a thinker of this cellular therapy and regenerative medicine in India. I'm grateful to you for giving me the past presidency and always encourage me to participate in such scientific deliberations. I'm grateful to all of you for listening. Thank you.
And in fact, in Indian Stem Cell Study Group side, we have got a lot of publications which are already being loaded, being done by the members. So we always propagate the young orthopedic surgeon who are in the institute, who are having an institutional ethics committee. They can go for our institutional stem cell ethical committee also, and gradually try to go for the different clinical trials, which are very important to establish us, because we are a place, a land, a country rich of the clinical material. Thank you so much.
And I have the clinical trials that I have made in my institute I'll send it to you. You can publish in the journal that you are publishing.
Definitely, sir. So kind of you. Thank you so much.
That paper I presented in Shankar Narayan oration in Raipur.
Correct,
Know that?
correct, sir. I remember.
So
I
you
remember,
can
sir.
publish that. That paper is with
Please
you
do
already.
send. Please do
Shankar
send.
Narayan oration you can publish in your journals or for the knowledge of the members. Of course, the members know it, but outside members, the other forums, the national and international level, the journal is the best vehicle of expression of our activity.
Definitely. Thank you so much.
So please,
Now
please
over
take
back
care to publish that.
Yeah, over
Thank
back
you.
to the convener of IUA Orthobiologics Subcommittee, Dr. Chinmoy Das, for the final remarks before we wind off. Dr. Das.
Yeah, thank you, Professor Khanna. And I am very grateful to you that you have conducted the meeting so well. And I think Patton said that if you have good soldiers, you can go to any war. So I think with you as our advisor, so I can take on any challenges that can be given by IOA to us.
Yeah,
So
we are
thank
all
you all.
soldiers together. Thank you so much, sir.
Yes,
Thank you so much.
yes, sir.
Thank you so
Thank you,
much.
Mahapatra sir. Yeah, thank you, the IOA President Ramesh sir. Thank you, our past President, Dr. B. Shivshankar, our Secretary, IOA Secretary, Dr. Naven Thakkarji, and Dr. Kanchan Mishra. You are doing a very good job, and I thank you for being present here and for your valuable comments. And also thank our young generation stem cell group members, our Dr. Madan, Shubham. So you all are doing very good job, and we appreciate it. And you have got a very good mentor in the name of Professor.
I think your signals are disrupting. Thank you.
Khanna.
Thank you so much, sir. Finally.
Thank you, everyone.
Thank you so much. So we're going to wind off here with a lot of thanks and regards to the IUA office bearers, Professor Sain, Dr. Naven, Thakkar, for having faith on us on the subject. So we'll try to come up with the next webinar soon with another interesting burning topic, which will be very important for orthopedic surgeons. Thank you so much. Signing off here. Thank you so much.
Yes. See you all in Agarwal.
Thank you. Yeah,
Calcutta.
And to all audience, in fact, we are just going to meet all together next weekend at Calcutta.
Yes.
The Argon is there, where we have the stem cell sessions also. So I'll request, and nowadays, now the things have been changed. We are now doing a workshop on the avian also this time in the ICON. So as been expressed today also, initiatives are required to unexplore those gray area which can be worked up from our knowledge. Thank you so much. Thank you so much.
Thank you. Thank you.